Thank you very much. This is a picture of one of the only mountains in the world that has never been climbed successfully. Okay. Sorry. Okay. Is that better? Okay. So this is a mountain called Meru, and there's a documentary on it, and it's either the only one or one of the only mountains that's never been climbed successfully until literally a year or two ago. And the relevance of this is that we are standing on the precipice of, I think, either curing or preventing the functional impairment due to Alzheimer's disease. And it will require a different approach, but it's not a complicated approach, it's relatively simple. We're very used to it in dealing with diabetes and blood pressure, in doing mammograms, colonoscopies, all these types of routine screenings that are designed to detect disease when it's asymptomatic. And the first prevention trials have begun. We're beginning to see patients in those prevention trials who are showing initial signs of cognitive improvement, even though they're completely functionally normal. So it's, in a sense, this Meru is like Alzheimer's disease, that we've really not been able to climb that mountain, but we are now standing, I think, on the precipice of Alzheimer's disease. These are the gentlemen who climbed Meru, and an interesting story is that one of them fractured two cervical vertebrae a year before climbing Meru. He was told he would never walk again, and he rehabilitated himself and joined the team, and in their second attempt to climb Meru, about this point, this is the peak of Meru, about this point he had a vertebrobasilar stroke. And they had to decide whether to go back or to continue going forward. And he said he'd rather die than go back. And in the documentary in this film, you actually can see that he's lost his speech. He's got vertigo. It's classic vertebrobasilar stroke. And they camped out that night on the peak here. And the next morning they climbed it successfully. So it's a dramatic story, much like the drama of really solving Alzheimer's and preventing functional decline is also. So I feel like we are going to be there very, very, very soon. So if we look at a couple of things, how does your brain do complicated things like cognition? And what actually causes cognitive impairment? What do we actually mean by mild cognitive impairment? It's not really that mild, honestly. And most of you are familiar with dementia. That's a much more severe stage, which unfortunately the majority of people are currently recognized in that stage. And that is the basis for most of the nihilism about degenerative brain disease, about cognitive impairment. We simply detect it when in the end stage of the pathology. And if we were to detect it much earlier, such as in the mild cognitive stage, or even before that, then the outcomes are going to be very different, because we can in fact alter the course of the disease. Well, do we know what causes AD? Well, if I were a basics researcher, I would say, well, it's not completely known. That's the standard response of all basic scientists. Nothing is ever completely known. We have a pretty good grasp on what causes AD, Alzheimer's disease. And how do we prevent or delay the onset of the functional impairment of Alzheimer's, as well as the functional impairment due to other causes of dementia? Well, it really boils down to three basic things. We have to identify and manage the risk factors for cognitive impairment. We need to monitor cognition annually after 50 years old. Now, this is very much like colonoscopies, mammograms. This is probably the most important thing because no one does a perfect job at managing their risk factors. We try, but there's always some risks that are going on. And the best way to pick up a problem that is treatable is to monitor for the earliest sign. And the earliest sign of the decline of Alzheimer's disease is cognitive impairment. Now, once we've identified it, we usually can now identify it in the asymptomatic stage. So at that point, we need to diagnose the underlying cause. We cannot assume that it's Alzheimer's disease. 45% of the time it is. 55% of the time it's not Alzheimer's disease. There are many, many other things, and they're easy to identify with a routine blood test and a picture of the brain. So, what actually how does the brain do complicated things like cognition? It really boils down to something extremely simple. The brain only does one thing. It communicates an electrical signal between nerve cells. And it does so through the synaptic connections from one nerve cell to another. And every brain disease, no matter what it is, if it produces impairment of brain function, it must impair synaptic communication. That is the sine qua non of any brain disorder. And so maintaining the health of that communication is the ultimate goal of a population cognitive health approach. Let's be clear about what mild cognitive impairment is and what dementia is, because we really need to move towards the detection of mild cognitive impairment and earlier and not wait. Just to give you a unfortunate piece of evidence is that if one simply relies on casual observation, the average number of years of symptoms of an individual with Alzheimer's disease before they are actually detected is 9 to 11 years of symptoms in terms of primary care physicians recognizing the cognitive impairment of Alzheimer's disease. So casual observation takes 9 to 11 years to detect the functional and cognitive decline of Alzheimer's disease. This is why we need more sensitive ways of annually checking cognition. Well, mild cognitive impairment is a condition where it primarily affects just one portion of the brain. That's this portion right here. This is called the hippocampus. It's right near your ears. And its job is it's a tape recorder. It records, let's say, the information you're hearing now, so that you can retrieve it a few minutes later up to a few weeks later. So it's a tape recording that has a duration of about 2 weeks, and it takes about 2 minutes to do the recording. And in patients with mild cognitive impairment, they have some damage there that causes an impairment of that ability to record and retrieve newly learned information. So in mild cognitive impairment, the classical symptoms would be things like missing appointments, forgetting to act on a recent conversation or commitment, repeating comments without realizing them, not being able to apply new knowledge to some job or skill or hobby. Those all require recording of new information and being able to retrieve it a few minutes to a few weeks later. That is the classical presentation of mild cognitive impairment. With dementia, you can see much more widespread tissue loss in the rest of the brain. These black folds here indicate marked tissue loss in the surface of the brain, the cerebral cortex. And at that point, the cerebral cortex is involved in the execution of well-learned skills, things you've known for years, things like paying bills or shopping or cooking or driving a car, well-learned skills, maybe playing the stock market if you've done it for years. You know, whatever it is your hobbies are and your routine responsibilities are, those well-learned skills start to become impaired due to tissue loss in the cerebral cortex in the dementia stage. So dementia isn't telling you that it's due to Alzheimer's or it's due to stroke or vascular disease or B12 deficiency or a head injury or alcohol abuse or a chronic medical condition that's not well controlled. It's simply telling you a level of severity, just like mild cognitive impairment is telling you about a level of severity. That's why I think it's actually kind of funny when you hear in my own colleagues who are very, well-learned and very smart in the Alzheimer's community, they talk about whether you can treat MCI or mild cognitive impairment. Well, that's kind of like can I treat pain? Well, if it's due to a compression of a nerve root, then I treat that. If it's due to arthritis, then I treat that. I have to know what the cause is before I can treat it. And so just knowing if a person has mild cognitive impairment doesn't really tell you what the treatment is. You have to know what's causing it. It's so fundamental that it seems like surprising that it continues to be discussed. Can you treat mild cognitive impairment? Of course you can once you know the cause. So if we look at it in a different way, look at it in terms of a timeline. Okay, in Alzheimer's disease at least, for about 30 years, there is an accumulation of the pathology. And this is true for most degenerative brain diseases. There's a long period of decades of accumulation of the underlying pathology. And at some point, it starts to impair the function of the brain in whatever areas it's located, such that one develops symptoms. And those symptoms would be the symptoms of mild cognitive impairment. So at this point, you can see this period of mild cognitive impairment typically lasts 7 years. And yet it goes largely unrecognized because we all, I think most of us at least, would acknowledge that as we get past 45 years old, we start to notice changes in our memory ability. I mean, that's well established in population studies of aging, that after 45, memory and other cognitive abilities are not as strong as they were. So it really becomes difficult to make this distinction between, well, is this memory loss that we're experiencing, is it aging or is it a disease? And so a lot of times people just go on and kind of hope that it's nothing. That approach ends up in recognizing whatever the disease is in the dementia stage after about 7 to 11 years. And at that point, you're really looking at widespread disease. So it would be like treating end-stage diabetes or end-stage renal disease and hoping for some miraculous improvement. It's not going to happen. There's too much tissue loss. When you look at people in this stage, the dementia stage, there is a way of aging them. I can tell you what their mental age is at different stages of dementia. In the mild stage, the age of an individual in terms of their reasoning capacity is 8 to 12 years old. In the moderate stage, when they start to have trouble deciding, what am I going to wear for this event? Or it's raining outside, I'm not sure what I should put on. Or it's hot out, what should I change? That level of mental skill or mental reasoning is 5 to 7 years old. And in the severe stage, you're looking at people who are under 1 year old in terms of their reasoning capacity. So the idea of trying to reverse the dementia stage is equivalent to the idea of taking an 8 to 12-year-old and converting them into an adult. It's not going to happen. There's too much damage. You have to intervene either here or even better, here. And the good news is that we have the tools to do that. They don't cost a lot of money. They're very inexpensive memory tests. The Vital Aging Program is one way to access that memory test, but the Vital Aging Program also works with you and physicians in the community if you wanted to implement it in your practice. It's also recognized by Medicare as important, so they've actually increased reimbursement for it as opposed to many of the things that they've decreased reimbursement for. So typically, a 10-minute test takes reimbursed at about $90 for a physician's office. For those of you who are interested in that, we can certainly visit your office, the Vital Aging Program, and help you get that set up. Or you can simply write a prescription and refer them to the Vital Aging Program for a memory checkup annually after 50. Now, what is it that causes cognitive impairment and dementia? Well, the simple answer, and it shouldn't be too surprising, is that brain lesions, as they accumulate, they cause cognitive impairment and dementia. And this is a study from Montine et al. In Seattle, Washington, where they took a managed care organization and they polled its members over 65, and they randomly sampled the population, and they said, would you submit to an annual memory checkup? And when you die, can we take your brain and do an autopsy? Okay, so they, being a managed care organization, they stipulated that they wouldn't take the brain until they died. And this is the group of individuals, when they died, their annual memory checkup was normal. So they had normal cognition the year they died. And what you see here are the 112 individuals on the x-axis. On the y-axis, that's the amount of pathology. And so as you go up here, you see more pathology. The different colored bars are simply, the blue bars are the pathology of Alzheimer's. The red bars are the pathology of stroke or vascular disease, and there are some green bars that are the pathology of Parkinson's disease. And you can see that quite a few patients have all three, okay? Some of them just have Alzheimer's pathology. Some of them have Alzheimer's and Parkinson's. Some of them have Alzheimer's and vascular disease. So mixed etiologies are very common. But remember, these people were all cognitively normal. They were functioning normally. They were cognitively normal. So even though they had the pathology, they didn't have impairment. And that is consistent with what we know about that accumulation of several decades where there's no functional impairment. Somehow, these individuals were able to delay the accumulation so they never became impaired while they were living. Now, if we look at the people who the year they died were demented or cognitively impaired, here's the difference. And it's very simple, that they had 3 times, on the average, they had 3 times the amount of pathology in their brains. And so this leads to at least a hypothesis that the amount of the pathology matters. It determines, to a large extent, whether a person is cognitively impaired or demented or not. Now that leads to a very nice preventive strategy, and that is, how do we reduce the accumulation of the pathology? And the answer is that there are ways to do that. So, first of all, we'll look at what are the causes, and you've seen on the previous slide the causes, but we have about 45% of individuals in the population, when they have cognitive impairment or dementia, it's due to Alzheimer's disease. And about 45% of the population who have cognitive impairment and dementia have either vascular disease or other chronic medical conditions that are not well controlled as the cause of their cognitive impairment or dementia. Now, these are very common conditions. Sleep apnea, very common. Diabetes, hypertension, not well controlled. Pulmonary disease, COPD, you name it. Hypothyroidism, not well controlled. Chronic kidney disease, not well controlled. Cardiac disease, not well controlled. All chronic conditions that are not well controlled that have ever been studied have been identified as risk factors for Alzheimer's disease. So it doesn't, and again, it gets back to something very simple. If you manage chronic medical conditions well, you're reducing the risk of Alzheimer's disease and other causes of cognitive impairment. So, how do we do that? Well, obviously good health care makes a difference. We can get benefit from the basic science literature in that if we look at conditions that increase the production of the molecules that cause Alzheimer's or Parkinson's disease or vascular disease, although it's not shown here, what you see is that all of the chronic medical conditions like blood pressure, stroke, heart disease, hypoxia, let's say asthma, COPD, sleep apnea, other causes of hypoxia, maybe increased platelets, etc. Obesity, low HDL cholesterol, high total cholesterol, high LDL cholesterol, high fat diet, diabetes, poor sleep quality, general anesthesia. All of these things increase the production of the lesions of Alzheimer's. The ones in blue increase the production of the lesions of Parkinson's disease. So this begs the need for good medical care in patients. I mean, that's really straightforward. And that, in fact, does delay the onset of cognitive impairment and dementia. Now, there are also lifestyle factors that you can do. I forgot to mention, there are some less common things, such as seizures, idiopathic hydrocephalus, hemochromatosis, and iron overload. In terms of lifestyle, the color in each box tells you which molecules are actually increased by each condition. So the brown here means that it increases both the tangles and the plaques of Alzheimer's disease, and the blue means it increases the molecules related to Parkinson's, and the red means that it increases just the beta amyloid, or the cause of the plaques of Alzheimer's disease. So in terms of lifestyle, things that actually reduce the production of these lesions would be cognitive exercise, where lifelong learning, like what you're doing today, those things actually reduce the production of beta amyloid. And they have looked at people and rated them in terms of the amount of lifelong learning that they have. And what they found is that people who engage in weekly kind of new learning, compared to people who do not, they have levels of amyloid in their brain that are about the same as 20-year-olds. Whereas people who do not engage in continued lifelong learning have levels of amyloid in their brain that are the same as people who are demented with Alzheimer's. Physical exercise, they find the same thing. If you do at least a half hour a day for 3 or more days a week, that actually lowers the production of amyloid and the molecules of tau and amyloid for Alzheimer's disease. And the more you do, the lower the production. The one useful clinical piece is that if you get short of breath or sweaty, that is kind of the key criterion of a half hour of exercise to be effective. Alcohol use is actually a well-established way to reduce risk of Alzheimer's disease. And it also reduces risk of Parkinson's disease. Obviously, alcohol is a double-edged sword. It's truly Occam's razor. It is certainly going to cause cognitive impairment if it's done in excess. But the studies from the United States and the Netherlands showed that 1 to 2 glasses of alcohol a day actually lower the risk of dementia by up to 70%. Okay? Whereas in France, they showed that up to 4 glasses a day. Now that study was done in Bourgogne, which, as you know, is the wine-growing region of France, so there may be a little population bias there. So you can see that there are both lifestyle factors and medical factors that can be addressed to reduce the accumulation of the molecules. And as you saw in the previous slide, reduced accumulation delays the onset of cognitive impairment to the point where one may never become cognitively impaired. So this kind of begs the basic notion, and in the 21st century, I think we can all accept now that the body is in fact connected to the brain. So what causes Alzheimer's disease? I think I've already kind of said what causes Alzheimer's, but I want to give you a little kind of a video or cartoon of how it works. So initially, what you see here, this is a nerve cell membrane right here. This is a plaque, a neuritic plaque of Alzheimer's disease. And it's hard to see, but I'll show you in another picture. This blue molecule here is a protein called amyloid precursor protein. And it is involved in the formation of the 1,000 trillion synapses in your cerebral cortex as you develop. And as you grow older, every time there's injury to the brain and there's damage to the connections, that molecule upregulates. And it helps either replace or repair the damaged connections. So what happens after it's done its job? Well, like most things, it's going to be cut up and it's going to get recycled. So that is the amyloid precursor protein sticking out of the nerve cell membrane. And what you see here is that occasionally, about 5% of the time, that precursor protein, that amyloid precursor protein, is going to get cut at the two sites where the gold bars are, the gold rod is. That gold rod is beta amyloid, and that is the initiating molecule that leads to the functional impairment in Alzheimer's disease. So once it's cut up like that, it tends to aggregate. And when it aggregates, it takes on special properties that are toxic to nerve cells. It interferes with the communication between nerve cells. Here's a synapse communicating, and these brown wheat checks looking things are the beta amyloid aggregates. And they float around the nerve cell. And they actually interfere with synaptic communication. That's one thing they do that leads to, ultimately, the functional impairment and cognitive decline. And they also do something else, and they affect the inside of the nerve cell. Here's the branches of a nerve cell. Kind of looks like roots on a tree. And inside these branches, what you'll find are microtubules. And these microtubules are held together by very fine proteins called tau. And I'll show you a picture of what the tau protein looks like. So this is the tau protein that wraps around the microtubules and it keeps them together. And it turns out that the beta amyloid causes these tau proteins to twist, and they pull off the microtubule. And when that happens, the microtubule unwinds like beads on a string. And the function of the microtubule is to transport nutrients to the synaptic connections to keep them healthy, because the synapses are the most metabolically active portion of the brain. They consume over 15% of all of the energy that goes to your brain. So they have to be well fed. And so the job of the microtubule is to transport the nutrients to the synapses. And when these microtubules unwind, that no longer happens, and the nerve cell shrivels up into a dense tangle. And that's where the neurofibrillary tangle term comes from for Alzheimer's disease. So there's a connection between the production of the beta amyloid and the development of the tangles. And that's fairly recently discovered. So this understanding helps lead to treatment strategies. We could reduce the production of amyloid through preventive risk factor management, good health care, lifestyle. We could also develop treatments that remove the beta amyloid or prevent the twisting of the tau protein so they don't pull off the microtubules. Both of those treatments have been developed and are being extensively tested in FDA clinical trials. There's probably over 17 compounds that are directed against beta amyloid and that remove the beta amyloid from the brain. They're antibodies. There are also compounds that bind to the neurofibrillary tau and remove it from the brain. So this is a very active area. These treatments are working. They're not cures yet, but that's largely a function of not being detected, the patients not being detected early enough. If we can start to detect the patients when they're normal, functionally normal, and we can do that with a 10-minute test, a 10-minute memory test, then we can initiate these treatments in the clinical trials so that hopefully they will never become cognitively impaired. So you can see that that is why the annual memory checkup is so important. So just to give you an idea, I call this prevention through delay, the impact of lifestyle and behavior. And this is, again, just reminder that reducing good health care and good lifestyle have a big effect. And this is an example of two identical twins. They're monozygotic, so they're genetically identical. And one of them was very proactive, and the other one was very inactive. They took the classical position. Their mother had Alzheimer's disease. They both have the highest genetic risks, that they're about 10 to 30 times more likely to get Alzheimer's disease. They have the same genes. And one of them says, I don't want to find out, I'd be afraid to know. She also didn't exercise, didn't watch her diet, didn't take good care of her health. The other one was very proactive. She wanted to get her memory checked, she watched her diet, she exercised, lifelong learning, good health care. They were both school teachers. Okay, so what happened to these people? The genes didn't matter, they had the same genes. Well, last year, the one who was afraid of getting tested and afraid of doing things died in a nursing home, end-stage Alzheimer's, mute, incontinent, wheelchair-bound, with a feeding tube. This one I saw a few weeks ago, and she was in a hurry because she was late for a tennis match. Okay, so there's quite a difference in the outcome as a function of behavior and lifestyle. The actual difference, if you quantify it using some standardized scales, is a 15-year difference in the rate of progression. And these are, again, people who are genetically identical. I reviewed the literature, and it turns out that that is corroborated in the Finnish and the Swedish national twin studies, where they showed that identical twins can differ in their onset of Alzheimer's by up to 15 years. So about 10 or 15% will differ in age of onset by 15 years. And it's large, it can't be genes. It's got to be something else. So if we look at examples from people, the public uses the Vital Aging Program. They don't have to be referred by a physician, although more than half of patients now are referred by physicians to have their memory checked. So this is a major shift. And what you see here is the memory score on the y-axis and time, about a year's time between two tests. Now, all of these patients have chronic conditions or various conditions that caused cognitive impairment. And once they were addressed, they all showed a 10 to 20% improvement in their cognition a year later. Examples of Parkinson's disease and depression, depression alone, severe stress, inactive physical and cognitive lifestyle, hypothyroidism, chronic fatigue syndrome, hypertension. This was a patient who developed a lupus attack, and their cognition was here. She came back a few months later after it had resolved, and you can see the improvement in cognition. So chronic medical conditions that are not well controlled do in fact impair cognition. And when you treat them, they get better. So hopefully I've gotten that point about annual memory checkups after 50, how important they are. To give you an idea of the power of the tool, this is the MCI Screen. I was involved in developing it. It is 96 to 97% accurate in making the distinction between a normally aging person and one who has cognitive impairment due to an underlying disease process. And it's very simple in the sense that it has a scale from 0 to 100. If the score is above 50, they're normal. They're normally aging. If it's below 50, there's some underlying condition that's causing a problem. It's not an Alzheimer's test. It is merely a traffic cop that is telling you, this person, we need to figure out what's causing their cognitive impairment. It's not just aging. And this person is aging. Like most tests, there's a gray zone right around the middle, the 50. So if you have patients in the 50 to 60 range and you have some suspicion that they may be having some cognitive problems, it's not unreasonable to pursue that. But in most cases, if there's no suspicion, then anybody with a score above 50, you can be 96 to 97% certain that they are aging normally. So if we look at the ability, what we can do today in terms of delaying the onset and progression of cognitive impairment, even if it's Alzheimer's disease, let's look at the impact of annual memory checkup after, 45 or 50, and how it can, in fact, delay the onset of dementia by 20 or more years. So this is a functional scale that is used by the Vital Aging Program. It takes about 2 or 3 minutes to actually stage an individual. And as you've seen, you can actually delay the progression, even if a person has Alzheimer's, by up to 15 years with just lifestyle and preventive approaches. If you don't do an annual memory checkup in an individual, they will typically be identified when they're transitioning from the mild cognitive impairment to the dementia stage, because that's when the well-learned skills start to become affected. That's when everybody realizes that something's going on. So that's what happens without an annual memory checkup. Now, with one, we can typically identify people either in a stage where they have no functional impairment whatsoever, which is stage 2, but they are aware of a change in their memory, or we can identify them when they have a change in their memory and it is in fact affecting more highly, not highly learned skills, but skills that require new knowledge. And so you can see the difference in years in the ability to detect with a memory checkup is about up to 22 years earlier it can be identified so that a diagnostic workup can be done and treated. Now currently, Namenda and Exelon galantamine or Aricept will delay the progression of Alzheimer's by 5 to 10 years if detected and treated early. So if you're identifying people here or here, you'll get about a 5 to 10 year delay with those treatments. They're not perfect, but they reduce beta amyloid, they reduce neurofibrillary tau to some degree. They also improve cognition for about 2 to 4 years, so that the patient goes above their baseline for 2 to 4 years, then they come back down to their baseline and they start to progress. But even then, that progression is delayed by anywhere from 33 to 60%. Now, if we were to combine the annual memory checkup plus risk factor management with early detection and treatment, then we can get that up to 15 years plus 5 to 10 years with current treatment. Not a new trial or anything, not a new drug, just current stuff. So we're really looking at 20 or more years that are possible with the current approach. Now with the newer treatments, we're going to do even better, but that's pretty good as it is. With that approach, when a person dies, even if they had Alzheimer's in their brain, they would probably still be functionally normal. So we would be able to eliminate the dementia phase, and most likely we'd be able to eliminate the mild cognitive impairment phase, even if they have Alzheimer's with this simple approach. Just to give you some background on how the program is structured, the Vital Aging Program, there is a professional component, which you're experiencing today. We're developing an online CME to make it more easily accessible for physicians. we also provide tools to their office for those who wish to do assessment in their offices. And we train physicians and have a physician network in Orange County of, I think, more than 400 physicians who've gone through training who are more comfortable at doing cognitive evaluation and diagnosis and treatment. We have the memory assessment service plus newsletter at the ocbrain.org website. And then we have public seminars where we educate the public in a similar manner so that they invoke a more proactive behavior and check their memory annually and look at their medical health and their lifestyle. So this is I see it as a bridge where at some point primary care physicians will adopt cognitive health into their repertoire. I don't know how many years that's going to take. We've been working at it for about 6, and we have made some progress, but the progress is, understandably slow. So this community assessment of memory is a bridge that physicians can use and the public can use until it's becomes routine practice in primary care. If we look at what happens with physician referrals versus subjects who are self-referring from the community, if a subject self-refers, about 25% of them over 65 are identified as having cognitive impairment. When physicians refer, patients about 55% of the time have cognitive impairment. So you can kind of see that there's the delayed recognition that's still happening in the physician practice setting, presumably because of the lack of time to be able to identify more subtle levels of cognitive impairment without some objective measure. So this is, to me, the most exciting thing. I started in Alzheimer's in 1988, where there was no treatment. And as a result of the Vital Aging program, an individual who was getting monitored over the first 3 years had shown a cognitive decline. They were functionally normal, so we were able to identify that individual when functionally normal, and they were referred to the prevention trial for Alzheimer's. It uses a drug by Lilly. It's an antibody that binds to beta amyloid called solanezumab. And this individual started treatment about 9 months ago, and when he came to my office, we repeated his memory test to see what had happened after 9 months on either placebo or drug. It turns out that he developed a side effect of eczema, so it's very likely that he was actually receiving the antibody. And if you project what would have happened if he had not gotten any treatment, it would have looked like this. His memory, he would have been recalling about 2 out of 10 words at about a few months ago. That's what would have happened without treatment on the average. Now, what we actually found was that after 9 months of treatment, his memory score actually increased from the previous time. That's a single data point. You have to kind of take that with a bit of caution. If I see a couple more data points like that, that's a lot different. So we may be seeing some of the first cases where if we can identify them when they're functionally normal, we may be able to prevent the functional decline of Alzheimer's disease. So to just close up, and thank you for your patience and attention, this is the next generation of tool. I kind of like this, so I'm just showing it to you. What you see here are two memory systems in the brain. You have actually three, but we'll just talk about two. The first memory system is called working memory in the frontal lobe. Now, working memory is extremely short. It's what people with attention deficit have a lot of problems with. Their attention is about 10, 15 seconds. The average person has an attention span of about 30 seconds. And it gets shorter as you get older, which is why when you walk into a room and you forget, why did I come in here? Okay? Now, I have attention deficit. I've been doing that since I was 7. Okay? But that's one memory system. And here's another memory system. This is the one affected by Alzheimer's. This is the one that takes 2 minutes to record and it stores for 2 weeks so you can retrieve. Well, what we've done was we took the Mayo Clinic's aging study and we took their memory task, and they had studied people who were normally aging for up to 10 years. And there were two groups of normals. One group remained normal over the 10 years. The other group developed Alzheimer's. And we were able to evaluate or analyze mathematically the simple memory test. And this is just an example of how we did it. Suppose you were asked to recall the word butter. Well, if we look at what the processes are in the brain, it goes into working memory, and there's some process that does that. We'll call it A. And then if it's retrieved with a different process, a retrieval process we'll call T. There's also the storage into short-term memory. It might get stored into short-term memory and then retrieved. And then after a short delay, it might be retrieved by another process in the hippocampus or the short-term memory system. And so there are all these different processes that are going on in your brain when you do a memory test or when you learn something. And unfortunately, when you take a memory test, typically you just get a score. They add up the number of words you recalled, and that's the score. And that's how it's been done for 100 years. Well, what we've done is we've taken your recall, your pattern, the words you recalled in each trial, and we converted them somehow to the underlying processes that are going on in the brain. And what you see here is in the green bars here, these individuals, they were the ones who were normal at the time of testing, and they developed Alzheimer's over the next 10 years. And compared to individuals who remained normal over the next 10 years, they actually increased the power of their storage. So they actually increased their storage, but when we looked at their retrieval processes, all of their retrieval processes were decreased compared to the people who were normal and remained normal over the next 10 years. So this identified people who were completely normal and predicted correctly that they would develop Alzheimer's within 10 years based on a 10-minute memory test, okay? That's a major methodological accomplishment, and we're in the process of converting this into the algorithms that will be used in the Vital Aging program to make the tool even better than it currently is. Just kind of a, FYI, it's kind of interesting stuff. So our goal is to detect people when they're asymptomatic, just like we detect breast cancer in the asymptomatic stage and colon cancer in the asymptomatic stage, because that's when we can really treat it effectively. And if we look at the cost, in the United States, there are 12 million people with mild cognitive impairment right now. The dementia-related cost is $1 trillion for that group. And currently, we could actually cut that cost in half just by mandating an annual memory checkup in Medicare. that an annual memory checkup of a sensitive tool. Just by doing that, we could cut that cost by $500 billion. We could do even better as the treatments for Alzheimer's get better and better. So we can make a substantial dent in the economic and the quality of life aspects. So to summarize, cognitive decline due to aging begins after 45 years old. 90% of all the causes of cognitive impairment are treatable, including Alzheimer's disease. And a healthy lifestyle and good management of chronic medical conditions can delay cognitive impairment by up to 15 years. Annual memory checkups after 50 years old are the keystone to preventing and delaying cognitive impairment and dementia. And detecting cognitive impairment while functionally normal changes Alzheimer's into a condition like high cholesterol. Thank you very much.